Welcome, friends. Today I chose for you a particular topic, which is cancer of the bile duct, or what we call cholangiocarcinoma. Now, this disease is pretty rare, but in the hepatobiliary circles, we tend to see quite a bit of this tumor. So it's called cholangiocarcinoma. And cholangiocarcinoma is the term that applies to cancer that has risen from the cholangiocytes. And the cholangiocytes are a special epithelial lining, which is related to the pancreatobiliary epithelial development in the embryo. They tend to have the same features. So any cancer in the cholangiocyte, whether it's in the very small bile ducts in the liver, major ducts outside the liver, or the distal bile duct, where the bile duct is inserted into the pancreas. Now, majority of these tumors are advanced at the time of the diagnosis. But if we look at them, they constitute about only less than 3% of all GI malignancies, and they express the tumor marker that we often check in pancreatobiliary cancers, which is the CA19-9, among other receptors and markers that are not used commonly. The disease is aggressive disease of the elderly, usually people in their 60s, 70s, and over. And most people who have cholangiocarcinoma, they in fact present at a stage where the disease is advanced and they are not resectable for a variety of reasons. Most importantly, there is either metastatic disease, or they are too comorbid, or the disease locally advanced where the surgeon won't be able to get a clear margin. Now, from an anatomic point of view, we divide the cancers according to their locations into three categories. And these categories are peripheral cholangiocarcinoma, and that applies to any cholangiocarcinoma that arises in the liver parenchyma. So it's called peripheral because it's peripheral away from the central part of the bile duct. So this will present as a liver mass, and as a liver mass, we deal with it like we did deal with the liver masses in the previous lectures. Second type is the perihilar, or the central cholangiocarcinoma. It's also called the Klatskin tumor, according to the person who first described it. And this often presents as a stricture in the hilum of the biliary tree. And we will elaborate on that in a minute. Or it's a distal cholangiocarcinoma. And distal cholangiocarcinoma, any tumor that is in the bile duct more than 2 centimeters below the hilum. Majority of these tumors are in the part of the bile duct that is traversing the pancreas, where it will be dealt with like any periampullary or pancreatic cancer. Now, it is important to know some of the predisposing factors for cholangiocarcinoma, but even with knowing certain risk factors, we know that majority of the cases do arise in a random fashion, and there is no predisposing factor. But there are known predisposing factors for cholangiocarcinoma, like patients who have primary sclerosing cholangitis. This is an inflammatory problem that affects the entire biliary tree, usually in association with inflammatory bowel disease, and more so with ulcerative colitis. These patients are problematic usually for the diagnosis, because sometimes it's difficult to differentiate between an inflammatory stricture and a malignant stricture. These patients often advance to have cancer of the liver, either in the form of cholangiocarcinoma or liver cirrhosis, and then they develop hepatocellular carcinoma. They all are also at risk of developing gallbladder cancers. Choledochal cyst. Now, choledochal cyst is a congenital abnormality of the bile duct where the duct is dilated, forming a cyst. And there are a few types anatomically of choledochal cyst, which is not the topic of today, but it is a disease that affects children and young adults. And if we don't remove it, it is a high risk for cholangiocarcinoma. Now, it's known that in Southeast Asia, there is a worm called Clonorchis sinensis, or liver flukes, a variety of form of liver flukes that you acquire from eating raw fish. And this is known, say, in countries like Singapore and Thailand, and it can predispose to cholangiocarcinoma. Patients who have liver cirrhosis, particularly those related to hepatitis B and C, are also at a higher risk of cholangiocarcinoma. Now, choledochoduodenostomy sometimes is a procedure that's fallen out of favor now, but it's used in the past as a diversion technique to away from bile duct strictures. Usually the strictures that happened as a result of either bile duct injury or recurrent cholangitis from stones. It's not done anymore because of the risk of developing cholangiocarcinoma. Lynch syndrome, we know these people have DNA instability, and as a result of that, they are at risk of having a variety of cancers, particularly colon cancer. But the risk of having cholangiocarcinoma is higher than the rest of the population. Diabetes and smoking are other risk factors. But despite that, we found that majority of people who get these tumors are in fact any person, and they don't have any predisposing factors. More importantly, the pathology of the cholangiocarcinoma is fascinating as well, and it is divided into three major groups. Now, the most common and the most invasive and aggressive cancer is called the infiltrative type of cholangiocarcinoma because it leads to perineural invasion and periductal and submucosal invasion, where the tumor will be invading all these structures without visible abnormality radiologically or anatomically when you open the patient. Very often these patients present with advanced disease with peritoneal metastases or liver metastases or lung metastases, and majority of them are not suitable for surgical intervention. The second one is the nodular type, and the nodular type is the one that forms a mass, which is just a nodule with no periductal invasion and no submucosal invasion. This is less aggressive. Every now and then we see a mixed type, which is a mixture of infiltrative and nodular, a mass forming, and also have the characters of infiltrative periductal and perineural infiltrative disease, and that would behave exactly in a similar fashion to the infiltrative. Papillary carcinoma of the biliary tree and the bile duct is rare, and it constitutes about 15% of all cholangiocarcinomas. It is presented usually on the MRI or the ERCP when we do the imaging as a mass filling the lumen of the bile duct, and occupying a space occupying lesion in the bile duct that could be demonstrated easily on MRCP or on ERCP. These tumors are very often curable, but they are rare. Now, how do we find about patients who have cholangiocarcinoma? How do they come to our attention? The major presentation is obstructive jaundice. They could have systemic features of cancer that could occur in any patients with any type of cancer in the form of poor appetite, weight loss, sweating, fatigue, fever, and possibility of epigastric pain and indigestion. Occasionally, lesions are discovered incidentally during the treatment or the investigation for an unrelated problem, where you suddenly find an asymptomatic stricture of the bile duct or asymptomatic mass in the liver, and when you investigate them further, they could be a cholangiocarcinoma. Every now and then, patients present with cholangitis because of the blockage of the bile duct. That stricture could lead colonization of the biliary tree, and that can lead to severe cholangitis where they need an emergency treatment in the form of decompression, either by an ERCP with a stent or a PTC, depending on which one is going to be more available and successful. And then they get treated formally after the sepsis have been treated, and they get evaluated for the possibility of surgery. A very important problem that we face when we deal with bile duct cancer is the bile duct stricture, and we need to discriminate between benign and malignant lesion. There are benign strictures of the bile duct, and if you take all strictures of the biliary tree, about 14% of them are benign. And the type of the benign is the following. You could have intraductal papillary mucinous neoplasm of the bile duct, very rare, but it's similar to what happens in the pancreas. It's pre-malignant lesion and it should be removed. The other one is a rare disease, which is IgG4 disease, an autoimmune disease that leads to autoimmune pancreatitis and also autoimmune cholangitis. This often happens in association with other connective tissue disease, such as Sjogren's syndrome and scleroderma, and so on and so forth. Inflammatory strictures of the bile duct are very common with primary sclerosis and cholangitis, and as I said, this is problematic very often to differentiate between benign and malignant strictures. Traumatic strictures, generally these are operative trauma after a complicated gallbladder surgery that can lead to injury of the bile duct, and that can eventually end up in a stricture that could need intervention. Now, once we found about these lesions, we need to investigate them fully, and the things that can help us to differentiate also between benign and malignant is the PET scan. While it's not very specific, but if the tissue around the stricture is PET avid, then that will raise the possibility of a malignant lesion. These days we have what we call a spyglass, which is the spyglass is similar to the ERCP, so it is a daughter and mother endoscopy, and the endoscopist will advance the spyglass into one of the channels of the duodenoscope, and they can actually cannulate the bile duct, go up the bile duct, and take some brushing or even taking biopsy from the stricture if they can demonstrate the stricture at the time, and it does increase our chances of picking and differentiating between benign and malignant strictures. In general, when we do an MRCP, there is a difference between benign and malignant. Malignant strictures are longer than 1 centimeter, and they usually show shouldering at the top end, and then a pattern of a rat tail pattern of tapering toward the end, which is suggestive. Also, the MRI sometimes shows us a mass in the area of the stricture, and that will help in the diagnosis. Any mass that's seen around a stricture is more suggestive of cancer of the bile ducts rather than a primary stricture. Now, what we found now is a patient who's jaundiced or have other problems, and we found on MRCP or other forms of imaging that they have got a biliary duct stricture. We need to work them up because the majority are malignant. And the process of working them up, we have taken the bloods, and after the history and the physical examination of the patients and their other medical issues, these specific things will be looking at their liver function test, which will be obstructive with very high gamma GT and alkaline phosphatase. CA19-9 is representative of the pancreatobiliary epithelium, and it usually goes up in cancer of the bile ducts. We need to see whether they have pre-existing liver disease or not, and that's particularly relevant in patients who have a mass in the liver, a mass-forming lesion. And the way we look at it, we do a quadruple phase CT scan of the chest, of the liver, the chest, and the abdomen. And the purpose of that is to differentiate the nodular lesion from a cholangiocarcinoma. Now, luckily enough, these days we have the luxury of having the MRI, so we do MRCP, and I prefer to do the MRCP immediately after the admission of the patient, before any form of intervention, because any intervention can change the picture that we see on the MRCP and the resolution of the images, which can confuse the diagnosis. And that's particularly applicable for lesions in the hilum of the bile duct or the Klatskin tumor. It doesn't matter so much if you have a nodular or peripheral cholangiocarcinoma or a distal one. Now, we obviously need to, after that, decompress them with usually a stent to relieve the obstructive jaundice. We often get a PET scan to rule out some metastases, and we do a staging laparoscopy to have a look at the peritoneal cavity. Cholangiocarcinoma is very well known to invade the peritoneal cavity and lead to peritoneal metastases, and that would preclude any radical treatment. Now, drainage procedure, when these patients are obstructed, as you see, this is a hilar cholangiocarcinoma. This is the typical appearance of the Klatskin tumor, where the biliary tree is dilated inside the liver, and the bile duct narrows down and normal after the confluence. So this is the cancer of the confluence, a central or a perihilar cholangiocarcinoma, and it's also called the Klatskin tumor. So after we go to an MRCP, we will get an ERCP for them. And in this case, we would, if we do an ERCP, we need to do two stents, one to the right, one to the left, while we are trying to stage the patients and thinking about the possibilities of the treatment. Very often we do prefer bilateral PTC if we know that there is a hilar cholangiocarcinoma. A lot of surgeons do prefer doing a bilateral PTC, which is a better drainage procedure with less risk of sepsis, and that's my personal preference. They seem to work really well, just as a peripheral drain without putting a stent and not traversing the stricture. Now, often you see our radiologist, lots of the times will be able to, in fact, introduce under fluoroscopy a biopsy for forceps via one of the bile ducts, and they will be able to get us a sample, and that sample could be either a biopsy or a brush cytology, similar to what happened with the spyglass, possibly more successful. We utilize also EUS, and the benefit of the EUS is going to be mostly applicable to distal cholangiocarcinoma, lesions that are usually occur in the distal part of the bile duct at the or just above the ampulla of Vater, and we will get FNA for that to ensure the diagnosis, and also we need to treat any sepsis in case they have any cholangitis. Now I'm going to show you this picture. This is the bismuth correlate, or just the bismuth classification of hilar cholangiocarcinoma. Now this is only applicable for the hilar cholangiocarcinoma, and it's useful for local staging of the tumor anatomically to think about what sort of surgery can be done for them. We will not dwell too much on this, but I will just make the image bigger. And type 1 is below the confluence. Usually it has to be 2 centimeters below the confluence. Type 2 totally involves the confluence. Type 3, we have got A and B. So the A involves the secondary radicals of the biliary tree. So in here, it's going up to the anterior sexual duct and the posterior sexual duct, both of them are involved. Type 3b is similar, but the secondary biliary radicals are on the left side. And type 4 is the worst one, which involve the biliary tree on both sides up to the secondary radicals of both lobes, and this is usually non-resectable. So you could imagine this one could be resected just with removing the bile duct and lymph node dissection. This one is usually treated with very often a hepatectomy, right or left, depend on the surgeon preference. Usually it is a right hepatectomy, bile duct resection, and then we join the left bile duct to the jejunum. Often this could be preceded by portal vein embolization of the right lobe, but that's a little bit too detailed. This one would be very suitable for a right hepatectomy, and this one is suitable for a left hepatectomy along with resection of the bile duct. Now, when we treat cholangiocarcinoma, when we treat hyalocholangiocarcinoma in particular, it's almost always mean that we will have to do some form of a hepatectomy, more often a right hepatectomy, in order to get positive margins. Now, positive margins in cholangiocarcinoma, I'm sad to say, is not very common occurrence. The margins sometimes are positive in up to 40% of the cases. So I'll recap on the surgery. If it is in the distal part, it will be treated like a cancer of the bile duct with usually a Whipple resection, and that will be followed by some adjuvant treatment. The perihilar, exactly like I said in the previous slide, which is usually in the form of a hepatectomy, and we often do portal vein embolization if we are aiming to do a right hepatectomy. We need to have enough future liver remnant. So if we are doing a right hepatectomy, it means that we embolize the right portal vein, we wait for a few weeks, make sure the left lobe has grown big, and then we do an extended, usually right hepatectomy that will take the bile duct, the hilum, and the right lobe of the liver, and we will be left just with the left lobe, and here we will do a hepatico-jejunostomy. That's the most common form of operation that you will encounter for cholangiocarcinoma. It is quite a complex procedure and associated with a high risk of complications, which could be in the form of either liver failure or leak from the hepatico-jejunostomy. Now, the last thing is that I need to emphasize that this disease is very unfortunately very aggressive, and we know that about 50% of people will recur within 5 years. That's of people who we have resected with a curative intent. The 5-year survival, we generally tell people it's somewhere between 20 and 40%, and that will be depend on the center and how they are experienced and how many cases they do usually per year. Often these patients will be palliated, and there is some form of palliative treatment that could prolong their survival. So they will need to be drained. Usually, if we decide to drain them, we prefer internal stents, so they don't have drainage bags that may preclude them from having chemotherapy. Diversion, that would happen in cases of distal cholangiocarcinoma that could be discovered and resectable during laparotomy, and then the patient will have a hepatico-jejunostomy, and then that will enable them to have palliative chemotherapy plus minus radiation, and the most common agents that used for chemotherapy would be cisplatin and gemcitabine. In these cases, or if you take all patients, the median survival in that situation will be about 12 to 18 months if they were suitable for palliative chemoradiotherapy. It prolongs their survival. Without treatment, the average survival is somewhere between 6 and 9 months. If they are deemed unresectable and we just put a stent and leave them alone, and that's the case in a lot of these patients because they often are comorbid and elderly. And then the only treatment will be treating their symptoms by internal drainage, and that can be achieved by either ERCP or PTC. Thank you for watching this video. I hope it has been a useful lesson, and I will see you in the future lessons. Thank you much.